Hey everybody, Karen Anderson here with Aortic Hope for our week in review. And there's a lot to review because we're still in the middle of Aortic Disease Awareness Month. So we just came out of big week of heart valve disease awareness and aortic disease awareness week for some organizations and aortic dissection awareness day. It was very busy, very, very busy week last week. So we're here to talk about it. And before we get started, I'd like you guys to just click like. Yeah, do that. Click like. It makes me feel really, really happy. And click subscribe. And if you subscribe to all, you'll get notified every time we go live. And we have a bunch of live events coming up in the next 2 weeks. So you don't want to miss any of those. So right now, I'd love to know your thoughts and your opinions on some of this. If there's things you want to contribute, questions you might have. I'm not a physician, but I'll sure try to answer them. So let's get started. All right. So last Monday, we talked all about the aortic valve. And we've already had a physician, Dr. Beavers, came on and talked about aortic valves. He was a new addition to our clinical team of speakers. So that was really wonderful. There was a lot of video, a lot of information in there that he wanted to share. And I think new valves from Edwards Life Science, which was wonderful. So let's just talk about that. Let's talk about the aortic valve. That's the only one we're going to focus on. And that is the right here. This is your aorta. This is your aortic valve. These are all the other big arteries and veins coming out of the heart. And they show you right here's the pulmonary valve. That's part of the pulmonary artery. Then you have, where else we've got a tricuspid valve right here. And there's a mitral valve somewhere in there. I don't think, oh yeah, there it is. Mitral valve sits just to the side of the aortic valve. So we're talking about the aortic valve, which is where all of the oxygenated blood that comes in to the body from the inferior vena cava comes in, and then of course it moves over to the left ventricle, and then it comes up and gets pushed through the aorta by going in the doorway of the aortic valve, and then it comes out and feeds the entire body. So it's like your heart's gateway. I mean, it really is. It's a very big swinging door. It's very important. Your heart, it's a rock star. It really is. And so the right side gathers up all that tired oxygen poor blood, and that comes from your body, and it ships it off to the lungs, and then the lungs give it this fresh oxygen makeover, and then it passes to the left side of your heart, which I had just showed you, and now your left ventricle is loaded with all this oxygen rich blood, and it's ready to deliver the goods basically to every muscle and organ in your entire body, which is still I find it fascinating. So before it can deliver all of that, it's got to get through that VIP gatekeeper known as the aortic valve. So the aortic valve, there it is. Normal aortic valve is going to have 3 leaflets or cusps. Okay, this is what it looks like when it's open, and that's what it looks like when it's closed, when it's in a pristine condition valve. Okay, all right. So this is the door between your heart and the rest of your entire body, and it usually has 3 cusps or leaflets, and they open wide when your heart is pumping, and then it lets, as we talked about, all that oxygen-rich blood, and it rushes into the aorta. And then once the heartbeat ends, that one beat, those cusps close and they shut tight to keep the blood from sneaking back into the chamber of the heart. Like any hardworking door, sometimes that valve is going to wear down. And it can wear down in 2 different ways. So one, it can have aortic stenosis. Now, what is that? Over time, the valve can actually stiffen and it can narrow. And so the opening becomes really small. The blood is actually struggling to get through, to get into the aorta, and it forces the heart to work harder to push it into the aorta. What would you feel if you had stenosis? You might feel some chest pain, some dizziness, some shortness of breath. And if it's severe enough, you could begin to have some heart failure. So a little blurry, sorry about that, but this is a healthy heart when the valve is wide open, letting all that blood in. And this is what it looks like when there's stenosis. It just can't close perfectly tight, so it becomes very narrowed opening. That's stenosis. The other thing that can happen is you can have a door that is just floppy because it's just like it's windy and it just keeps flopping in and out in all different directions. That's regurgitation. Okay, so the valve is not going to close tight, and so it lets blood escape back into the heart, not the direction we want it to go. So that means your heart has to do double duty to basically push that blood out, and that can lead to a lot of fatigue, can lead to some chest pain and discomfort, and definitely issues when exercising. So again, normal valve operation, the blood just kind of flows in. When you have regurgitation, it's flowing back out, back into the heart. That's what I have. The other problem that you can have is that you're not born with three cusps or three leaflets. So stenosis and regurgitation is something that you will develop over time. I'm sure there may be babies that are born with that. I don't think so. I've never really heard anybody talk about it. But that's something that develops over time with a lot of wear and tear, probably due to high blood pressure and other issues. But that's something that develops. Bicuspid aortic valves or an unocusp or quad cusp, anything that's not your normal three cusps is something that you're actually born with. So that's considered a congenital heart defect. It's not your fault. It's probably hereditary. Somebody else in your family probably has one, but that's only two cusps, two leaflets. So instead of having the three that look like a triangle, it's got two. That's it. So it kind of has to work a little bit harder than it should, and it's more prone to developing stenosis or regurgitation earlier in life. Again, here's your normal aortic valve, right, which sits right in here at the beginning of the aorta coming out of the heart chamber. This is bicuspid. So you can see this, what would have been a division between two sides, it never came apart. So it fused together in utero. You're born with this. So it then looks like you have two separate leaflets. And now the crazy thing is if you have one, I'm not even sure what that would look like. I think it just comes and opens from the side because that would be one leaflet. But if you had four, this would have a division, this would have a division, and you would have four separate leaflets. That's also very problematic. So somehow in the human body, three is the perfect number. Anything other than that, it's going to cause you problems. So your doctor can actually run tests like an echocardiogram, non-invasive, right? That's just like a ultrasound on your chest. Or they can do a very quick 5-minute CT scan or even an EKG to see if your valve is too tight or if it's too leaky or if it's actually just built completely different. And mild problems usually just need monitoring. They just stay on top of it and keep track of how it's going. But if the valve starts to get severely narrowed or leaky, then the doctors might recommend replacement. So the options would, because there's no medication you can take to clear up stenosis and open it up. And there's no medication you can take that stops the regurgitation. Although, unlike an aneurysm, which we know doesn't shrink, valves can get a little bit tighter. They change, they're not stagnant. So you might find yourself having an echo and they tell you you have mild to moderate regurgitation. But then 6 months later, you go back for another one, they say, well, it's only mild. So that could indicate that you had better blood pressure control or something else changed in a positive direction that led you to now have a little bit better of functioning heart valve. So it can change. That's why it's kind of tricky. You kind of have to see it changing in the wrong direction, more towards severe, and staying that way before they're going to really consider doing some kind of replacement. So there's surgical, okay? It's called a surgical aortic valve replacement or SAVAR, and that is going to be your classic open heart surgery. Sounds so bad for us as patients, right? Especially if we've been through a dissection and when you've had open heart before, you know what you're facing. But it's so much easier for a physician because they get full field vision, right? They can see everything. And they like to do it on younger patients. So at 56, I'm still kind of considered young, which is awesome because they consider me young, but it's also not great because I know that means I'm going to have an open heart surgery. You can also now do a transcatheter aortic valve replacement or TAVR. So that's minimally invasive. They just basically go through your groin and or your shoulder or your neck and they can deploy a valve. That's typically done for older patients or individuals who cannot tolerate open heart surgery. It's easier for us, but could present challenges to a physician because their scope and their field of vision is going to be limited. And if there's an emergency, they're going to have to still cut you open to get to it. There's nothing you can really do if something bad really happens and they're using a catheter up your groin. So this is kind of what it looks like. This would be stenosis. This is a great picture of stenosis, by the way. Lots of hardening areas on that valve. So it's coming up through the groin into the heart and can go right into that aortic valve right there. And the catheter actually deploys this, not the whole thing. This is the bubble of the catheter. It's just this meshy looking part, wire looking part. That's the valve. And so they'll deploy that. They cannot do transcatheter with mechanical valves. Mechanical valves don't bend easily to fit up through that tiny catheter. Only bioprosthetic, meaning cow or pig valves, can actually be done transcatheter. So if you're deciding that it's better for you to have mechanical, you're going to have open heart. As of today in 2025, that's just the way that it works. It really depends on your age and your overall health and risk factors as to which surgery is going to be the best. We haven't even gotten into the valves yet. We'll get into that in a few minutes. But your aortic valve might be small, but it is truly mighty and it really keeps that blood moving. So it's fueling your body with oxygen. If you ever notice chest pain, okay, or if you're dizzy or you're unusually fatigued, it's really worth asking your doctor, excuse me, to take a look at your valve, just to do a quick echo, and they'll be able to see. And if you wanted some more information about this, there's tons of links in the post on the website, but we are going to get into a little bit more of the options as far as valves in a little bit. So that is the basics on aortic valve disease. Well, who do we have with us today? Is it quiet?
Well, let's say hello to Christina and Natalie and Tom. Tom would like
Oh,
to share
wonderful.
that he has a mitral valve clip with a Watchman.
Okay, very good. I'm looking at getting a pig valve. That's what I will be having coming up soon. But welcome, everybody. Thank you for joining us. We are going to hop right into. So, this is about women in heart health and Global Heart Hub, which is an organization that we are an affiliate of, that we partner with. Their theme for Heart Valve Disease Week was all about women and heart valve disease because the presentation can be very, very different. And last year was a totally different campaign. So this year, they really want people to understand how often women's health in general, not to mention heart disease, is really, it's overlooked. This is based upon research globally, a whole global perspective and stats that I don't have up here. Um, and when they developed this campaign, it was through a meeting, I believe, in Milan earlier this year, that all this information was tabulated. And this is the outcome, which is a very unfortunate outcome. But, heart valve disease affects women the same as it can affect men, but we are typically underdiagnosed. We are usually diagnosed much later in the process, and we tend to be treated at a later stage, which will often lead to a poor outcome. So, too many women have their symptoms dismissed as anxiety or part of menopause. I was told that too for a long time. I was told both of those actually, or just stress. And it isn't. It's very much, I have a severe valve regurgitation. So it's really time for physicians and for people to start to think about acing their healthcare journey, especially women, and looking at their health a little differently. We have to try to work to advocate for ourselves to ensure that as women, we have timely access to diagnosis, to treatment, and just to overall care. We have to take our own heart health seriously, and then we advocate for our physicians to do the same. So when people tell you, oh, it's just menopause, don't just leave it at that if you know that something doesn't feel right. It is incumbent upon us to have to ask for additional screenings. It's just very important. So we really just wanted to help promote that campaign and really share it with all of you, and it's an additive to acing your healthcare journey for women. Okay. It's something that you need to really think about, I think, when it comes to all of your healthcare issues. A lot of times it's very easy to say 1 + 1 = 2, unless one of those ones are hiding behind one. Then it could equal 3 or 4, right? We have to sometimes ask the extra questions that force the physicians to listen to us and not just make a very easy diagnosis. Delve into it a little bit more. They have to stop blaming things on other things that they're not even working with to fix, like menopause, like what was mentioned in this article. So take that to heart, think about it. Hopefully, it resonates with you and it helps you ace your own healthcare journey. My soapbox, I just came off of it. Okay. I appreciate all that hard work from our members at Global Heart Hub and Heart Valve Voice US. Okay, let us continue on. All right. Now we can get into the aortic valve treatment. Now's the fun stuff. Okay. Now's when we get to look at the valves. So, we've talked about aortic valve disease and how our valves can fail over time. And it is so common for valves to fail over time. It's almost all the time that if you went for an echo, that it's going to say mitral valve, trace regurgitation, pulmonary valve, trace regurgitation. This is normal. It's so that trace is like minor because no door shuts completely airtight, right? There's going to be some air that gets into the door and the door frame. So that's normal. So it's never something you really need to worry about at the trace level. As it starts to change, people should start to take notice, okay? So it goes trace, then it goes mild, then mild to moderate, then moderate, moderate to severe, and then severe. Okay, so if you have mild to moderate disease, then doctors usually monitor the progression, and that's with an echocardiography, right? Echocardiogram, and they manage your risk factors like high blood pressure, and they are going to encourage you to stop smoking. If you ever wanted to see things go south fast, smoke. It impacts all of this. Okay, it impacts all of it. It impacts so much in your life. When you reach that severe aortic stenosis or regurgitation stage, the only proven treatment option to improve your symptoms and overall extend your life expectancy is to have that aortic valve replacement. Right? Doesn't sound fun. Believe me, I'm not having any fun with processing all of this in my own mind. So one of the first decisions that you make is whether are you going to choose a mechanical valve or a bioprosthetic valve, which means tissue valve. And I already knew going in. I knew what I was not choosing. That was mechanical. I wasn't choosing mechanical. And the great thing about that is that the physicians already agree with me. And we're going to go through the pros and the cons in a minute. But all right, let's get to this. So when you do mechanical, yes, it's very, very durable. It probably will last you the rest of your life. Okay. 30 years now, right, on average, and things are only improving over time. They are typically recommended for younger patients, okay, because you have to be on lifelong blood thinners. So older people can fall, they break their hips, they hit their heads. You don't want to be on this type of blood thinner at that stage of your life. So they are typically recommended for younger patients. You have to have regular blood tests. Certain things in your diet can impact the blood thinner that you're on. And a lot of patients can actually hear a clicking sound and people sitting next to them. No way was I doing that. That will make me go bananas. I am already at night with earplugs in, paying attention to the arrhythmia that's going on in my chest. There's no way I was going to have clicking sounds. I don't care how many people tell me they can barely hear it. That was not an option. And I really don't want to be on blood thinners like that for the rest of my life. So, and they didn't want me on it. That made me happy. So we were kind of thinking the same. But here's a great picture of a mechanical, and they're great. For people that have them, they're happy with them. Obviously, they feel great. They're doing great. You can't do transcatheter though. Remember, you have to have open. But here it is, just sitting right in there. Boom. There it is. And what's ironic is there aren't 3 leaflets. It looks like there's just 2. So I don't even understand, but that's fine. I don't need to. All right. Your other options, bioprosthetic, and that means you can have a cow valve or a pig valve. I one time asked if we're so closely related to the ape family, right? Why aren't we using any of their valves? And the answer was because they're not comfortable with utilizing those animals for the testing. Because cow and pig we're already using in our foods as a food source, right? The primates we don't use as a food source. So it's not anything that anybody's ever thought to really test, I guess. What they have found is that pig and cow work very well. Okay. Durability anywhere from 10 to 20, closer to 20 years. Every physician I've spoken to is about 15 to 20 years. They are more prone to some calcium buildup because they feel and act just like our tissue. It's not an actual valve, okay? It is tissue from inside the pericardium that they place. You'll see it. I'm going to show you in a second that they place over. I have not actually, I think I went and I did see people making them, but I watched them making grafts. So I haven't seen the people actually make valves yet. But there's a very low risk of blood clots. So you don't need to be on a blood thinner, which is really great. And you're not going to have to worry about rejection. This isn't like an organ that you're rejecting. Okay. They are often chosen for older patients, okay? But, and that's because, again, of the blood thinner, but younger patients might need a second replacement later in life. So, again, you can do this. You can replace this 2 or 3 times, believe it or not, if you make sure that they give you a valve that's larger than the space you already have. So, this is kind of what the tissue looks like. Just the tissue part is this part where the cursor is right here. This is all man-made, and this is the tissue. And that specifically has 3 leaflets right there. 1, 2, 3. Okay. Now, trans catheter, right? Or surgical. These are the 2 ways. So again, we talked about it can go up your groin and deploy it via catheter, or it's going to be open heart like this. There's so many lines, it blows my mind away. Transcatheter aortic valve replacement, minimally invasive. We've talked about this already. The catheter delivers the valve through an artery. Often the groin can be neck or can be wrist. Takes about 45 to 90 minutes. It's quick, very quick, compared to 4 to 5 hours if you're doing surgical, right? Takes about 1 to 2 days in the hospital, and then you go quickly back to normal life. There could be a need for a pacemaker. Sometimes there's a risk of valve mismatch. This is so not good for me to be reading right now, but that's fine. And you're limited by artery size on what size that you put in. But after talking with my surgeon, he is going to try to put in a larger size so that there's spaces there. So in the future, I can have one deployed via TAVR and they can go up and just pop one in already. What's there? That's what they do. They go in, push open those cusps, and just start the new one right up. Kind of amazing, right? All FDA approved transcatheter aortic valve replacement valves are bioprosthetic. Your other option, you could do surgical aortic valve replacement. That's a traditional open heart surgery. That's what I'm going to be having. That allows the surgeon to go right in, directly remove the diseased valve, and repair any surrounding areas. I had an ascending dissection. That's where it started. Then it went all the way down into the left iliac. But I have an ascending graft. He's actually going to cut through that graft, go in to go ahead and do the valve replacement. I don't really care how he does it. I want to get the whole thing over with. But that's what he was drawing out on a piece of paper for me. But they can address valve disease and aneurysm. So he can look at the work, make sure everything looks good when he's in there because he's right there. And if anything doesn't, he can go ahead and fix it. They say recovery takes about 1 to 3 months. I know he said he's fine with patients flying after a month. This should not be as shocking as a dissection because first you have to deal with the shock of being told that you have a dissection and you could die. You have to move very quickly. There's the shock of saying goodbye to friends, family, loved ones, whatever, if you're able to. There's the shock coming out of the surgery. You've just been through a major surgery. So that's why it typically takes about a year when you've had an emergency surgery versus a planned surgery like this. Hopefully, fingers crossed, back on my feet in a month to 3 months. I got a lot planned that I want to do. So I'm hoping. And then there's cardiac rehab. So this is how the doctors decide. If you are an older patient, 75 years or older, or you have multiple health conditions, okay, you are a better candidate for a transcatheter valve replacement. You just are better than doing open surgery. And it's due to the faster recovery. Okay. If you're younger, meaning under 65 years old, and you can tolerate, open heart surgery, then they're going to steer you that way because, especially if you want a mechanical, you have no choice if you do mechanical. But patients with bicuspid valves, aneurysms, or coronary artery disease probably will benefit more from having open heart because they can address all those things at one time. So that's the post on treatment options. I hope that you find it beneficial and you learn something from it. But obviously, talk with your physicians if you find yourself in a position where you're going to need to have your valve replaced, and go over all the pros and cons. Touch these valves, ask for show and tell. Understand a little bit more about the mechanics behind them and the decisions why, if you were their relative, they would tell you to do what they're going to tell you to do. But at the end of the day, it's really your choice. It's really your choice. So that is that. Anybody have any comments about what we're talking about so far?
Well, we can welcome a few more people to chat.
Okay.
Molly, and please and thank you, and Terry, and Melissa. And everybody's just saying hi to everybody. Like a
Hey,
lot. There's a
everybody.
lot of highs
All
going
right.
on. High
I just
fives.
dropped my piece of paper with everybody's name on it, and I like to have it handy. All right, everybody, you go and have your highs, have your powwows. I like it. And we're gonna move on because this was some exciting stuff that happened. So last year and this year, we've had the Marfan Foundation um, publicly express their support for Think Aorta campaign, Think Aorta US, and Aorta Cope, which is just wonderful. It's so wonderful to be able to work with them and to have them understand the importance of thinking about the aorta, because really, at the end of the day, everybody falls underneath the umbrella of Think Aorta. They just do. It might not be in their business plan or in the forefront of their mind, but they are, because they wouldn't have a job to do if a physician wasn't thinking about the aorta, right? So this year, um, we pulled together with a lot of people and really realized that time is life. Okay. You have the power to save a life today. And we wanted people, and we still want people to share this crucial message stat. Spread the word about signs of aortic dissection ASAP, because what do we know? We know awareness saves aortas, period. So what is stat? Stat is suspect. Suspect that it could be an aortic dissection. T stands for time. That time matters. We want physicians and people to act quickly. A stands for aortic imaging. We want that important CT scan, that life-saving imagery that would lead to life-saving surgery. And T stands for talk about it. We know that dissections run in family, and like Think Aorta says, think aorta, think family, have those conversations and learn about your family medical history. So we are together for aortic disease awareness, and we wanted to give a shout out to all of the organizations that came together for the first time: North American organizations, Marfan Foundation, the Genetic Aortic Disorders Association in Canada, John Ritter Foundation for Aortic Health, Loeys-Dietz Syndrome Foundation, Loeys-Dietz Syndrome Foundation in Canada, Rock from the Heart, Think Aorta Canada, and Think Aorta US. So hopefully you can think about STAT, or at least think about how uh, awareness saves aortas, period, and think about ASAP. So that was that important post for you guys. Okay, this is just bonkers. So we got this new director of illumination, Daphne Joy Grant, and she pulled off just, I think it became 23 locations. We had a last one come in like September 17th, and this had already gone up. Boy, I'll tell you, out of all of those, I'd say 90% of them all went off without a hitch. It's amazing. I still can't even believe that she was able to have all of these locations light up for aortic cope and aortic disease awareness. And we are so excited to bring a video to you this week that's going to show you still photos and video presentations from people all across the country. And I have a sneaky suspicion we're going international next year. So, oh my goodness. We had, okay, the City Hall in Baltimore under construction. Didn't happen. The International Peace Bridge in Buffalo connects Buffalo to Canada. Happened. Beautiful. Can't wait to show it to you. Rock and Roll Hall of Fame. Happened. Beautiful. Deep red. It was phenomenal. That was out of Cleveland, Ohio. I don't know what happened with the planetarium. I'm thinking it happened because I saw it lit up when I went there. So I'm assuming it was. I've been looking for it on live cam. That was out of St. Louis, Missouri. The Lowry Avenue Bridge in Minneapolis lit up in purple and red. That was so wonderful. That was great. I-35 bridge, struggled a little bit to find the bridge. There was some issues, but that's okay. City Hall in Tuscaloosa, that went off. Gorgeous fountains, that looked beautiful. Intermodal facility also in Tuscaloosa, and the fountain lights at Alberta Park in Tuscaloosa. Boma Building in Philly, that was lit up. Symphony House condominium in Philly, that was lit up. Um, The One Liberty Place in Philly, that was lit up. The Lower Trenton Makes America Takes sign, that was lit up. The New Hope Lambertville Northampton street bridges in PA and New Jersey, it's a foot traffic and a car bridge, that was lit up. We had the Hillside Monogram M on Box Springs Mountain in Moreno Valley. That was lit up. The Stone Bridge in Johnston, they had it on their Facebook page. That was lit up. Skydance Pedestrian Bridge in Oklahoma, I'm unsure about, but the Johns Hopkins Dome, that was gorgeous. That was lit up. Niagara Falls Illumination Board, thank you so much. They lit up. Oh my gosh, it was red and purple. It was just so exciting. It was so exciting. Mayo Clinics, we believe, lit up around Rochester, Phoenix, and Jacksonville, and all the way just basically across Minnesota and Wisconsin. The sales at San Diego Convention Center, that got lit up. And that was our last one of the entire weekend. So I just can't believe it. It's just very exciting to have had all of that lit up. And we're just so excited that we were able to light the way to aortic disease awareness. And thank you, Daphne Joy, for pulling off what we thought was the impossible things of the weekend. But you did it. And we are so excited to make this even a bigger event next year, with hopefully having some meetups across the country, getting some press releases out there, and maybe even going international. And I'm thinking, I mean, I know we did when we were in Canada, I'm thinking Australia and New Zealand, because now we are fully supporting their Facebook page and providing them with all of our resources. And I think that's where we're headed. So we'll know next year. It's so exciting. So shout out for Illumination and shout out for aortic disease awareness. I'm just still giddy about it. I just am. I had so much fun jumping in and out of the car around Trenton and Philly, some of the most safest places in the country. It was fun. All right. What is today? Oh, the sale just ended, but there'll be another sale. We were letting everybody know last week. We had a sale from the 17th through the 21st. It was 20% off of every single thing on our shop. Everything you couldn't have got, you could have gotten as much of whatever you wanted with 20% off. So you do want to check back every now and then. You don't need a special code. You just click redeem, and whatever sale is going on, whether it's a percentage off or free shipping or what have you, don't delay. Grab your swag today and wear it proudly to spark conversations about aortic disease awareness. And it's not just items that you wear or your mugs that you're drinking out of. The point of the matter is they're conversation starters, right? So every shirt, every bracelet, every water bottle, everything spreads awareness and helps you really carry forward our mission, which is to create hope and provide education and awareness and spread some support to anyone impacted by aortic disease. And I will tell you, more times than not, if I'm decked out, somebody's stopping me and asking me either what is Think Aorta, what is aortic hope, did you have something wrong with your aorta? And they always want to know more. And it is amazing when you're on, for instance, Facebook, and you click on aortic hope and you click on the number of followers we have and you invite others and you send it to all of your friends, okay? They still have the option to join or not join. But it is inevitable that some of your friends either know someone, if not themselves, they know someone in the neighborhood, family member that has aortic disease. They just didn't know about aortic hope yet. So it's very helpful when you can wear the swag or invite your friends to join the page and invite them to join our YouTube channel, because somebody is going to understand aortic disease and all of a sudden feel light bulb moment. Now I have support as well, and I have some accurate resources at my fingertips. So yeah, shop, share, shine together. We are making a difference. One story, one conversation, one person at a time. So keep your eye out on our Hope Shop, on Spreadshop, because there's always going to be another sale. All right. Any chatter I need to know about? Do I have any food in my teeth anybody's talking about?
Well,
No?
there's no food in your teeth that I see. There's a
Okay,
bunch
good.
of thank yous about the content that you create.
Aw.
Came in from Natalie and Tom. Molly wants to share a quick anecdote about her conversations when it came to picking a valve. And she
Okay.
says, I tried asking the surgeon, if I were your wife or daughter, what would you suggest? Did it work? He
And
didn't fall for it. He basically said, you need to make this decision for yourself. She was so embarrassed.
that's
Please and
horrifying.
please and thank you
Well,
is listening in from work, and they share
yeah.
sometimes when I'm in these labs and I start talking to a coworker or take a phone call, I freeze because my brain glitches and I think I'm on a Zoom with a live mic. That's fun. That's very fun.
That's so funny. That is
Molly's
so
got a couple
funny.
things to share. She says, I love the illumination campaign. I want to see it huge next year with boots on the ground in every location.
Yes.
She also says, Hope Swag definitely strikes up conversations. Go get 'em, aortic hopers.
I like that. Well, to Natalie and Tom, thank you very much. It is a massive group effort from our med students and our residents to Molly and her team of social media assistants, everybody that is, I mean, look, September is our absolute busiest month. There is 30 days of information. Everybody, including physicians, think we're insane, but they can't believe we are able to actually touch upon almost everything in 30 days. And I do have to leave some things on the cutting room floor because I don't want to bombard everybody 5 days, 5 posts a day, 7 days a week, but it is a group effort. It is more everybody else. I got to give hats off to Sarah Copeland for snazzing up a lot of our moving posts that you guys all enjoy. But it's an all day from the moment that Molly sticks up her quotes to we have all of our medical content or down to our contests from Sean. It is Joyce and Nikki and everyone, and they just do a fantastic job. So that's your team. And thank you for acknowledging that. I appreciate it. We all appreciate it. Okay. That brings us to aortic dissection guide. You guys have heard of this. I probably have like 3 copies laying around. Of course, I clean my office and I can't get to any of them. Not, I didn't clean my office. Terry cleaned the office. If you have not checked out the aortic disease guide yet, you need to. And there's no way that you can say you can't get one because you can download it for free. You can order a hard copy for free. You, more importantly, should tell your physicians to order a box of 25 books for free. Everything's for free, 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 free. Okay. Whether you've received it from your hospital or you downloaded it, it's a resource that's really designed to walk with you every step of the way. What are you going to find inside? Okay, you're going to find what's an aorta. Of course, we start off our guides like that, but you're going to learn about aortic aneurysms, what they are, how they're diagnosed, how they're treated. You're going to learn about aortic valve disease, including stenosis, regurgitation, bicuspid valves, and how they're diagnosed and how they're treated. You're going to learn a little bit about aortic dissections because if you had one of those, you should be checking out our first book, which we're going to get to. You're going to learn about medications, what you might be prescribed and why and what it's doing for you. You're going to learn about exercise, safe movement, activity, lifestyle tips. You're going to learn about genetics, okay? The role of hereditary conditions and family screening, and so much more is in this book. Because aortic disease is so complex, every person's journey, it's amazing. Every person's journey really does look different. And this guide is going to help you on what's relevant to you and your diagnosis and your health profile because you kind of almost need to look at these guides as a map, right? Not every road is going to necessarily apply to you, but the right ones will actually guide you towards the best care, towards realistic expectations, and probably provide you some confidence when it comes to treatment and recovery. Okay. And I find the best part about these books is it may educate you about something that you might end up having in the future. So then it's not necessarily as scary and going in blind, right? Families and caregivers. Now you're also going to find there's a special section in the guide set up and designed to help you understand your loved one and what they're going through. I need to bring this book down to my husband. He needs to read it. Aortic disease, look, it can be very life changing and support, whether it's helping to manage your blood pressure or encouraging healthier choices or simply just going to an appointment. It makes all the difference. Let me tell you, I had Terry at my appointment. I don't even remember. I remember a lot of the appointment. Let me be real. I was very, very well prepared, but she took copious notes and he drew everything out. It's all part of my documentary. He drew everything out on the paper that goes on the table that you're supposed to sit on that I never sit on. And I feel like I was well armed with a lot of questions I knew I wanted to ask. I gave her a moment to ask questions if she had some, but I think we both were just, it was so much information. He was so um, thorough that after I asked questions that were important to me, like pain management and recovery, and making sure that they knew that the moment I register and the minute they put that IV in me, I want some feel good medication because I don't want to be waiting till it's my turn, and I don't want to be stressed and full of anxiety. So I want them to give me a lot of something to take the edge off. I'm fine if I don't remember any of it. I'd rather fall asleep, say like my goodbyes, and fall asleep instantly, like in the room waiting to go into the surgical room, than to be stressed out. Like I'm stressed just thinking about it. So I'm already rereading our book. And so I'm suggesting to you that you take the time with the guide. Like mark the sections that really speak to you and your personal journey and use it as almost like a trusted companion when it comes to navigating aortic disease. And look, you can download a copy here. If you just go to our main page, you can't miss it. Okay. You have your free download. It's right there. Right there. You also can go ahead and order bulk or convince your physician to order it in bulk for free. You have your hard copy order form, and look, survey. We need you guys to fill out the survey for the aortic disease guidebook because it really helps us when it's time for us to update both books in the future. What you have to say about these books matter. It's more than the fact that we give away a prize every month for the first year after a book's been launched. Your thoughts matter, and they did help us when we listened to what you had to say after the dissection book, and we took everything under consideration when we were building this book. And we will take things under consideration as we begin to build out our third book. So that's just right on the main page. It's also under resources. It's also under Hope Shops. Don't tell me you can't figure out how to get it because it's there. So it's there. Just saying. You should get a book for yourself and get one for your loved ones. Okay, moving right along. ASAP. One of those other things that just come up into my head at 2 a.m. I don't know. But it's true. Awareness saves aortas, period. It's a very easy thing to remember. We want to talk about awareness, ASAP. Because when you hear ASAP, what do we all think about? We think about as soon as possible, right? But for Aortic Hope, during Aortic Disease Awareness Month, ASAP means something so much more powerful. It means awareness saves aortas, period. And yet kind of fits in with the whole as soon as possible theme, right? Because we're looking to have people diagnosed and treated as soon as possible. Raising awareness about aortic disease can actually make the difference between life and loss, and many lives are saved when symptoms are recognized quickly. So when people know their family history, anything, like don't take anything for granted. When you know your family history, heart disease, stroke, diabetes, cancer, aneurysms, and when the community pushes for education, for screening, for support, early recognition matters. Knowledge saves lives. Your voice spreads awareness. So this month, and really every month, we need you to shout it loud and clear, ASAP, because awareness saves aortas, period. Share this message, educate a friend, share all of this stuff on your page. It's not just about you and your immediate family. I'm telling you, trust me, your friends, it'll amaze you. A third cousin of a friend that you went to high school with is going to maybe reach out to you and say, what's all this stuff about aortic disease? I actually need to have my valve replaced. And you're going to be like blown away. And it happens all the time, daily, right? So share the message, educate a friend, and help us save lives one conversation at a time. ASAP. Do it ASAP, you guys. Okay. I get excited and tingly about that too. All right. We're moving on. It was officially Aortic Dissection Awareness Day on the 19th. It's also Pirate Day, Talk Like a Pirate Day. I'm not sure why they chose that day, but it was chosen right when I came into the community. I had no say. I was just excited to be part of it. So let's talk about dissections because it was Dissection Awareness Day last week. You can always follow along pages 13 through 23 of the patient guide, the Aortic Dissection Patient Guide, which was the first guide we put out for more information. But we should all know this by now. An aortic dissection is a tear in the innermost layer of the aorta. The innermost layer is the innermost layer. There was my parents' Brooklyn accent. The innermost layer, the intima. The middle layer is the media. The outer layer is the adventitia. The innermost layer tears. Okay, and that causes blood to rush in there and accumulate between the intima and the media, the innermost and the middle layer. And so the dissection refers to the visual splitting of the aorta, creating a true lumen, which is an actual true area that the blood is flowing and providing blood to the organs in your body. A false lumen from this tear creates a channel where the blood might flow through there, but it doesn't go anywhere. Malperfusion doesn't provide blood to other areas in your body. We want that area to thrombose or to clot because we don't really want blood just flowing. So it will eventually stop. One would only hope that the true lumen is larger, but I don't think it tends to normally be larger. I think the true lumen or the true remaining aorta, which could be like the size of a straw, tends to be smaller than the area that's not really real and feeding blood anywhere. Here it is. So this is looking at the aorta, not through. This is at like super highway. That's why they call it that. This is your blood flowing along the highway, and boom, we have a tear in that innermost layer. Okay. So now when you have this tear, here's a side view, cross view. When you have a tear, it's going someplace that's like, I don't even belong here. I don't care. It can re-enter also. So it's like nobody knows what this section is. What is it doing here? It's doing nothing, serving no purpose. But you want to make sure you still have blood flowing to the rest of your body and your organs to give it that oxygenated blood. That's why the true lumen's so important. There it is, tear in the aortic wall, right there. Okay, two types of main dissections, and Dr. Ben Udelman just discussed this the other day. So he made it even more simpler. It's the first time I've heard him say this. Usually he says type A dissections are ascending, type A, ascending, which means coming out of the heart and ascending, going up, right? Till it gets to the point of the arch, which is where those three very important branches come off, go to your arms and go to your head. And then it becomes descending, or he would call it type B, bascending, ascending. Now he just calls it surgical and non-surgical. I think that's even better. Forget A's and B's. Did you have one that required surgery, or did you have one that didn't require surgery? It's because types A are more dangerous because they occur in the upper ascending part. This is where you have the most blood volume. It's coming right out of the heart. And so sometimes it can extend a little bit downwards towards the abdomen, goes all the way down, right? That would be a complete A. The treatment for type A. It's going to almost always require emergency surgery to help replace that part of the aorta that was torn and restore the appropriate blood flow to the rest of your body. Depending on the extent of the dissection, your surgeon might perform a hemiarch repair, and that's where they replace the ascending part of your aorta only, or a total arch repair with or without an elephant trunk. I know you're probably thinking, what is all this? This is insane, right? Hemiarch, just the ascending. Total arch would include your arch. Elephant trunk includes your elephant trunk, the part that's coming down. Okay. That helps with more emergency, extensive dissections. All right. So here is your hemiarch. No valve replacement, by the way. This is a graft, a Dacron graft. This is taking care of an ascending dissection. It's in the ascending, coming out of the heart and going up. Simple. Hemiarch. All right, this is a type A repair. It includes the arch and frozen elephant trunk, or FET. So this is your valve, right? This is your ascending. This is your arch, with part of it going to the branches to your arms and your head. And it included a stent that is down inside the aorta. See, this is on the outside of the aorta. This is going inside the aorta. That stabilizes all of this mess of a dissection in here. So a type B, or descending actually, right, involves a tear in the lower or descending aorta, meaning that's where it originated from. So the ascending part is not going to be affected. So you can have a tear in the ascending and it go all the way down, still an A. A for astronomical, for amazing. B is only here. It's only in the descending part. It's not going to include the arch or the ascending. It's just anywhere down here into the abdomen, right? So they're typically medically managed or non-surgical at the initial diagnosis point, as long as blood flow to your abdomen and organs and limbs are unaffected. Because remember, your ascending is very important, right? Because it's got all those branches right off the bat that go to your brain and some of your limbs. But when you get to the lower part, you've got celiac, which does your celiac artery. That does your stomach, your intestines, your pancreas, spleen, liver. And then you've got the renal, which does the kidneys, and then you've got femoral, which takes you down into the iliacs, into your legs. I mean, there's a lot of important stuff in the lower half of your body too. That's why it's also abdominal ruptures can be life-threatening. So as long as your limbs and your abdomen area isn't really affected, they're just going to handle a type B non-surgically and just do it with medication. Sometimes they might put an endograft in, right, in your descending aorta to kind of help reinforce the aorta, expand that true lumen because they put a stent graft in, opens it up, and cuts off the blood supply to the false lumen. So it gives you all, it's keeping all of the blood, the good blood is coming into the true lumen because they've cut off the false chamber, the false channel there. Small cut in your groin, they go up, artery, and that's it. Really isn't like a full surgical cut down thing that you have to worry about when it comes time for a type B. So here you go. Here's the initial tear. It's right here. That is a descending. This is true lumen blood, true lumen. This is the false chamber that's been created by this tear that was here. It created false blood flow. This blood flow is not going to anywhere. It's not going to feed any organs. It doesn't connect to any of the other arteries that come off of the aorta. They put this graft in here and that expands this and allows more blood flow to go down this area in here. Okay. And then we just hope that this clots off. This is where it comes back in and tears back in. See? And you've got blood supply going off here. So the diagnosis of a dissection actually requires some sort of imaging of the aorta, and a CAT scan is going to be your number one golden diagnosis technique. It just is. It's the golden standard because it's so fast. It's so fast that in the ER, that's what they're going to give you. Even if you're allergic, they may do it without contrast, or if they think you've got enough time, they might do a quick pre-medication. But you're not bumping somebody and pulling them out of an MRI and waiting 40 minutes for that. That's not happening. They can actually visualize the entire aorta with a CT scan, which is useful because then they can decide right away, is this type A or is this type B? Additionally, your doctor might actually order contrast, right? Even though we're looking to do this very quickly, because it really does help distinguish between true and false lumen and checks for organ perfusion, meaning want to make sure that your organs are they're being given blood. They're receiving blood. Here, you can see it right here on CT scan. That's a nice little tear right there, dissection. I do not know. My guess is this is false lumen and this is true because I thought that they were typically smaller. This could all be false and this is true. I don't know. I wish it would have said that because now I want to learn something. But conversely, an echocardiography can help show aortic dissections in unstable patients that cannot have a CT scan. So they can always pull this up quickly and grab a probe and take a look. But it's not going to provide high quality imaging. I mean, look at that. I mean, you can see a tear, but it's not going to give you anything that's high quality. And certain parts of the aorta, like the distal ascending aortic arch, anything that's on the backside, you're not going to be able to see it with an echo. You're not going to be able to see the lower half as well. But we really want you to be aware of early symptoms. It's very important to kind of get an idea of early symptoms, and they're not all going to be a ripping, tearing sensation. That is just crazy to think that everybody feels that because they don't. You'd be amazed at how many people really feel like close to nothing. They just might feel off. And that's kind of scary because that could be anything, right? You're not going to necessarily see it on your blood pressure or it's not going to show up on an EKG. So you might not even have an increased heart rate. Your pulses might be different, but are you going to be consciously thinking, let me check my pulse on different sides? Probably not. Look, the more common presenting signs to facilitate early medical intervention would be sudden shooting chest pain, upper back pain. Maybe it spreads to the neck or it could go down the back. You could have sudden stomach pain. You can have all of a sudden sudden neck pain. You could feel faint. You could have a loss of consciousness. You could feel shortness of breath. You might have some vision changes, especially if you tore in the ascending, because all of a sudden the blood flow is completely different. It significantly probably reduces as it flows into a false chamber, and it could mess with things. I'm not a doctor. I'm just telling you all the things I've heard people say. Difficulty speaking, weakness or paralysis on one side of the body, weak pulsation in one arm or one leg compared to the other. The pulses might be off, pain in your lower extremities. Here's some other things that they think are very common. Typically happens more to males. Definitely for abdominal. That's for sure. I didn't know that it typically happened for males for outside of the abdominal area. Older age. These are all the things that I think are just fallacies not to necessarily pay attention to. High blood pressure, for sure. For sure, that's a big one. If you have atherosclerosis or hardening of your arteries, that could lead to it. If you have a bicuspid aortic valve, that definitely could be a contributing factor to an aneurysm and or dissection. They're very closely related. Turner syndrome, which is a chromosomal defect that only happens in women. If you find out you have Turner syndrome, I would be definitely on higher alert about the chances of a dissection. If you find out you have Marfan syndrome or Ehlers-Danlos, or Loeys-Dietz connective tissue active 2, if you find out you haven't, you have not had a dissection and you start feeling things that feel off, I would be concerned. And I would be mentioning all of these things when you go into an ER. I would say, look, I have Marfan's, I have weird chest pain. And they should take you right back to a CT. They don't. Advocate, communicate, educate them on the importance. Pregnancy. Okay, so our hearts grow like what, 3 times their size, I think, when you're pregnant. If you have any other conditions and you're pregnant or you don't, but something feels off, I would make them they're going to want to do an echo. I don't know that they would do a CT and radiate you while you're pregnant. If you do intense weightlifting and you feel any of those sensations that were mentioned above, you definitely want to make sure that you force your way in the door for that CT scan. If you're a smoker, too, or if you've had a family medical history, these are very important things to share with your EMT or the ED department staff in advocating that you have a CT scan. You got to get that CT scan. So hopefully you learned something from this. We do have our first guide, which is also available, where I showed you on our main page of our website on resources and Hope Shop, and that is Aortic Dissection, the Patient Guide. And that's where the majority of that guide is going to really focus on everything to do with dissections, and you'll get a ton of information there. So hopefully you found this informative and it helps you down your journey. That's that. Anything I need to know about that's going on? They're probably like, blah, blah, blah. We're just going to talk amongst ourselves while Karen talks.
Oh.
Okay.
So Molly poses a pretty good question here.
Sure.
Can the dissection tear to the adventitia and create a false lumen there?
It typically, from my understanding, tears through the first inner 2 layers. Yeah. If it tears through the adventitia, that's a rupture. If it goes
That
through
actually
all 3.
gets asked and answered here early, a little bit later. Where am I in the chat here? Yes, Gipbra. More thanks are coming in. Gipbra says, "You're the greatest. Thank you for all your help and info. Legend in my
Thank
books.
you.
Welcome to chat, Gipbra."
Thank you. Thank you.
Natalie says, "Very good question, Molly. I also wonder about the rupture mechanism." And then she says, "Rupture would imply a tear in the intima and media and adventitia." Wow, that's a mess.
Yeah.
And
You want to
then-
know something even crazier?
Okay.
I'm just going to give you a visual. Hopefully you can see this. Okay. So this is tissue paper that was wrapped up in a gift. It's very, very thin. Right? You can see through it, right? You can see my pen right through this. This wet, 3 layers of this wet is what a physician feels when they go in to operate. It's like thinner than tissue paper, each layer. But so the adventitia is the most, I think, fibrous. That's going to be the hardest one to get through. And that to me is crazy that we just have 3 layers of this. And those of us with the dissection have compromised 1 or 2 layers inside. Like, isn't that wild? I don't mean to scare you guys, but it's pretty crazy when you think about it. That's what they're trying to sew something to, is like wet tissue paper.
Yeah.
I don't know why. I find all this so fascinating.
And so Molly says, well, I just learned that my dissection actually breached/ruptured the outer wall and clotted, and he stitched it
Yeah.
during surgery. So
Mm.
that makes me think, is my dissection a false lumen in the outer?
It could. And then if it bubbles out, that I believe is a pseudoaneurysm. Those are very serious. I could be wrong. I don't think I am, but I could be, but I don't think I am. So you might want to look
This
in
is
the
a
book.
good time to remind everybody that tomorrow at 6:30 we'll be having an Ask a Doctor with Dr.
Oh
Prakash
my God.
on
Yes.
Facebook.
Yes. And here on YouTube. So he's going to be on Facebook. There's going to be a post that pops up at 6:30 p.m. It's going to be pinned to the top of the page, and you will be able to present all of your questions that are going on in your head to Dr. Siddharth Prakash. He's out of UT Houston, and he will answer all your questions. That is a public channel. So if you want to remain anonymous, we do have an anonymous link in the post, and we will ask it for you. But as you are asking questions on that page, I am sharing them live here on YouTube with Terry Cook. We're talking about it and we're talking about the answers. And then as you guys chat questions into us here, they are being texted or added to Facebook. So it's simulcasting. It's like so technological, right? It's pretty exciting. We like that. Okay, everybody. Aortic Dissection Awareness Day. I only heard about these Mythbusters. I don't even know how I missed this from our friends at Aortic Dissection UK and Ireland, but they from Think Aorta, from that group over there. So the mothership of Think Aorta created these 8 myths about aortic dissection, and I just think it's fabulous, and it's just on like its own card and poster. So here's the myth, and I'm going to give you the fact. The myth: acute aortic dissection is extremely rare. In the UK, aortic dissections kill more people per year than road traffic accidents. How you like that? So here in the United States, we do talk about how aortic dissections are rare and aortic disease is much more common than you think. But in the UK, it's more fatal than a traffic accident. Very scary. Myth: acute aortic dissection always presents with a ripping and tearing chest pain. And the facts are, the key defining feature of an acute aortic dissection is sudden. It's a sudden onset, and it can be severe pain, but doesn't always have to be severe pain. It can be at maximal on onset and then subside. I did have that. Pain can be transient or migratory and can occur in the chest, in the neck, in the back, in the jaw, or in the stomach. That's why it's so hard to always rule in an aortic dissection, because think about this. In the United States, regional medical centers might see an aortic dissection 1 a year. Literally, they get maybe 1. Larger hospitals can receive 20 or 30 or more in a month, right? They get so many dissections in a year, but your regional might see 1. So they're not always thinking aorta when they see somebody, especially somebody who's active and, obviously they enjoy physical activity. They're thinking muscle pull. If you get somebody who is known to have Crohn's disease or IBD, they're thinking it's that. It takes a lot of information, such as knowing that there could be a parent that has an aneurysm, right? Or a family member who died suddenly and they ruled it a heart attack. That's why Think Aorta campaign is so important. That's why Aorta Cope talks about it often, because if you can talk about your family medical history, if you know you have a connective tissue disorder and you experience something onset and sudden like that, it's a better chance that someone will think, well, maybe it could be their aorta, and at least check the pulses and the blood pressure in both arms. And if they see things are off by 20 points blood pressure wise, then they're going to order that CT scan for sure. Not 100% of the time, but we hope so. All right, myth: acute aortic dissection is not a genetic condition. Up to 30% of aortic dissections are caused by hereditary syndromic or non-syndromic aortic disease. 30%. I mean, that still leaves 70% of us not understanding why it happened, but it does not mean that it is not genetic. It just means we may not have discovered your genetic condition, but it is more than likely going to end up over the years being a genetic connection. 30%. That's pretty high. Myth: Aortic dissection is a condition affecting individuals over 65 years old. Nope, it occurs in younger patients. It does, particularly those that have genetic issues like Marfan syndrome or vascular Ehlers-Danlos. Do you know that out of the 30% with these types of conditions, 50% of those people are going to have an aortic dissection? That's a high number, you guys. Misdiagnosis is quite common in young people and especially in pregnant women because when aortic dissection, which is rarely considered, um, it ends up being the leading cause of maternal cardiac death. Okay, myth. Acute aortic dissection patients always have poor outcomes. There is this fallacy going around that all of us that survived a dissection were of the 1% or the 2% club. That is not. I don't know where that graphic came from. It bothers me, but that is simply just not true. It's not true. You have a 20% chance of dying initially from a dissection, but an 80% chance of living if you go to a hospital, if you can get there, if you think there's something wrong with you. So many people don't ever go. They just don't think it. They wouldn't know. They just don't know, or they don't feel that bad. Or they go and they're misdiagnosed or underdiagnosed and sent home. Right? So it's not a 2% club. Your chances of passing away go up every hour by 2%. That might have been where the confusion came in. Patient survival and outcomes improve with early diagnosis and prompt intervention. That's just a fact. So an aortic dissection is treatable. It's treatable, and there is now a very large community of survivors thanks to advancements in medicine and surgery. There was a time almost 11 years ago when I came into the community that it was on Google. It may still be on Google actually, where it says that if you had an aortic dissection, you'll be lucky to still be alive in 5 years. Forget about 10. I mean, 10 would be amazing, but 5, you'd be very lucky. And that was true. And it was true because there was a time not that long ago, maybe 20 some years ago, where if you did not know that you had Marfan's, Ehlers-Danlos, or Loeys-Dietz, because ACTA2, I think, was discovered in the last 20, maybe 25 years. If you didn't know that you had something, they didn't follow you. It was you're fixed, go live your life. You'll never need to come back. They didn't know. They knew to follow people with connective tissue disorders, but they didn't know that they only represented 30% of the population. They didn't think to follow the 70% of us. That's why we kept dying and we didn't have longevity of life. But now they know. And so now there are people in this community who have been here for 40 some years after a dissection, multiple heart surgeries, been celebrating 30 some years on their aortiversaries, right? There's no reason that we can't live as normal of a life and as long of a life as we were deemed to live before our dissection, because now we're all being followed, right? We all have continuing monitoring of our lives. So, fallacies. All right. You cannot CT scan everyone with suspected acute aortic dissection. And I think a lot of people thought that. That's why people don't make it, because you just can't stick everybody in a CT. Look, it requires a CT. It requires a CT or an MRI of the entire aorta, blood tests. It requires a chest x-ray, an EKG. These are all things, or an echo, in order to 100% define. So your CT or MRI or echo are going to 100% determine if you're having type A dissection. Blood tests, not going to show anything, okay? But they're going to do them to make sure you're not having a heart attack. EKG, standard protocol. That's not going to tell you if you're having a dissection, but it will tell somebody if you're having a heart attack. An echo can show if you've had a dissection, but again, only in the ascending area. Your two best tests are always going to be an MRI or CT. So you really do need to do that if you suspect a dissection. Fallacy. We need to reduce the number of CT aorta scans because they are costly. So think aorta's diagnostic strategy of increasing the index of suspicion for aortic dissection and lowering the barrier to CT scans. That's endorsed in the UK by the Royal College of Emergency Medicine and the Royal College of Radiologists. That is what they believe. We have to, and we should be doing this in the States, we have to create easy access to the CT scans and lower the costs because insurance just doesn't cover enough. We have to do it. because that's the way to figure out if you're having an issue with your aorta. And people need to stop worrying about that they're going to be glowing in the dark. I had 15 of them in my first year. There's a thing called cost benefit analysis. If you need a CT scan because you think something's wrong, you get the CT scan. I don't even think, and I'm going to have a radiologist come on and talk to all of you, the low radiation CT scans, and let you know exactly how many x-rays they equal, because I think it's like a 1-on-1 or something like that. It's not like 15 to 100,000 x-rays equal 1 CT. It's really not that bad. Not when it comes to life or death. There is no way to really worry about quantifying that. All right, our last myth. Algorithmic approaches are best for diagnosing an acute aortic dissection. I know that's a myth. And I know so much of it is going to be done now by AI, and I would not be here if it were left up to AI and many other people. So I find all of that very concerning, because I didn't know to ever mention my father had an abdominal aneurysm. I mean, they knew I had Crohn's disease, right? But it could have just been a Crohn's attack I was having. Everything was presenting, it was reflux. They may have just said, send her home. Medicine is still best when people can lay hands on a patient. And if they had not laid hands on me and listened via stethoscope and did blood pressure checks and just boop, 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 put it all into a computer, it might have very well said, send her home. So it's going to be a while before I'm very trusting of that. But clinician Gestalt, informed by Think Aorta, has been credited with improving aortic dissection diagnosis in the UK. The optimum diagnostic strategy currently is Think Aorta CT scan to confirm. That's what it's about. So Think Aorta campaign this year is tackling dangerous misconceptions, and that's why they put out this busted 8 myths of aortic dissection. Frontline clinicians, paramedics, emergency room director teams, radiologists, and acute care providers. The question was asked, how many of them would bet their reputation on these myths, right? The myths cost lives. They just do. And all of this that's down here goes into more of the information I read above. Listen, despite advancements in imaging and treatment, up to 40% of dissections are going to be missed at first presentation. Too often, because outdated thinking clouds judgment, right? So you can get a copy of this Mythbuster. The link is in this post from last week, and you can talk about it as well. And maybe the US will adapt something like that as well, similarly, because I think it's important. They're the most common misconceptions when it comes to dissections. There's probably a ton of them too when it comes to aortic disease. So hopefully you got something out of that. Okay. That brings us to our Survivor Series Saturday with a very, very lovely man named David. I think it pronounced Fail. Hope I didn't butcher that. Look, we want you to be the shining star in someone's life. We want you to share your story as a patient or a caregiver. We want you to share your story if you lost a loved one, because their story needs to be heard, whether it's an aortic valve disease or whether it's an aneurysm, whether you've had a dissection, it doesn't matter. Your ability to validate someone else's experience is not only therapeutic, but it's inspiring. So help us show others how to thrive and not just survive. You can sign up. You can tell your story in written form, which I'm about to read to you. You can share it in video, pre-recorded, or you can go live and take questions from everybody that is out here like you guys. All right. From David, I'm going to read it. It's exactly how it's written. My younger brother went to the hospital emergency room with an abdominal aortic aneurysm. It was misdiagnosed and he was discharged. He returned when the pain got worse and was admitted and went into surgery. He survived for 70 days in the hospital ICU. On my next visit to my PCP, I was told that there could be a family connection and I should ask the cardiologist to order testing. When I told the cardiologist that I needed testing for aortic aneurysms, the response was insurance doesn't cover that, so we're not going to do it. I offered to pay for the testing. On my next visit to the cardiologist, I asked again, and the response was no response. Having spent more than 50 years as a pilot, including experimental test flying, and the last 25 years as a pilot on search and rescue, police helicopters, I was well trained in making critical and life-saving decisions. I made another life-saving decision and called the cardiologist's office and asked for an appointment with a different cardiologist. Yes, that's good. With my next cardiology appointment scheduled for 6 months, I had to insist on the next available appointment. After that appointment and a scan, I received a call from the cardiologist's office asking me to come in the next morning. I had a thoracic aortic aneurysm. That's a TAA, and not so large that I was on my way to the hospital, but large enough to require frequent scans, which showed a steady increase in size. There was a scan that was at 48 millimeters, that's 4.8 centimeters, and identified as a penetrating ulcer inside the TAA. A referral to the Yale School of Medicine, Center for Advanced Thoracic Aortic Disease, and I was starting a journey that dramatically changed my life. Because of the TAA location, my aortic valve would have to be replaced with the TAA repair. I continued to exercise carefully right up to the day before surgery on August 16th, 2023. After a hospital stay that had to be extended, I was home 2 days before my birthday. The next couple of months were spent gaining strength by multiple walks each day and working with a physical therapist 3 times a week. After 2 months, a visit with the surgeon, and he said I no longer had to ride in the back seat of the car. I forgot about those days. He said I could drive, and I asked if I could go to the gym, and he said yes, but take it slow and no weights. My first outing was to the gym where they were surprised to see me. I rode the recumbent stationary bicycle for 5 minutes and called it a day. Each day after that, I added 1 minute to my bicycle ride. A few setbacks, including mitral valve regurgitation, palpitations, and now the beginning of an abdominal aortic aneurysm. Still going to the gym every day and exercising at home. Connecting with Aortic Hope makes life better. A caring group who provides meaningful information and connections. Thank you so much, David, for sharing your wonderful story. That's great. It's a good story. All right. Last check in. Anything I need to know about before I begin to wrap all this up?
Go ahead and wrap up, and then we'll check in at the end.
Sure. Okay. We just finished off the week with the spoon theory. I love the spoon theory. I came across the spoon theory before I ever had a dissection because I have Crohn's disease. And whenever I hear somebody, I used to hear people say I'm out of spoons. I just didn't understand what that meant. But it really helps others understand what's not visible to them, why someone cancels plans or seems fatigued or needs extra support. It kind of helps build this visual understanding, and it builds empathy and patience. So the spoon theory was written by a woman who has lupus, and she has a couple other comorbidities. She just got so oh, she also wrote a book called You Don't Look Sick. I'm pretty sure everybody's talked about that book at some point, whether they read it or not. But You Don't Look Sick is what it's called. She needed to find a way to explain to people what it's like living with limited energy every single day. So imagine when you wake up, somebody hands you like 30 spoons, a handful of spoons, a lot of spoons. And every activity from getting dressed to making food to driving to work to managing stress, it all costs you one or more spoons. Okay. Now, for people living with chronic illness or pain or fatigue, spoons, they run out a lot faster. So what might cost the normal person 1 spoon to brush their teeth could cost somebody with a chronic illness 2 spoons. What might cost you 2 spoons dealing with stress at work costs other people 3. Even small tasks start to feel really overwhelming because energy is a limited resource. So when the spoons are gone, for people, they're gone. Normal people, other people that don't have health issues, they can borrow spoons into tomorrow because they have all this endless energy. When our spoons are gone, they're gone. Okay? Why does this matter? Because it actually helps to explain invisible illnesses and struggles so that people can help they can actually understand you. Right? So I've actually had somebody say to me, "But you have the energy to take a trip with Aortic Hope. You have the energy to do a live event, but you can't put away laundry." I guess who said that? Or had other people make similar things like that. And it's just a different energy. It's an on energy. This takes energy, trust me. But it's very different. Okay, so doing laundry takes a lot to get down the stairs. Folding it and bringing it back upstairs could take me a week before I put it away. Takes too much spoons. I don't have enough spoons. When you explain the spoon theory, it helps to remind us that people with chronic illness They often have to make tough choices and tough decisions about how they're going to spend their energy, how they're going to spend their spoons, right? How they're going to use their spoons. It helps to encourage compassion, patience, and support from family and friends and caregivers. So the next time someone says, I don't have enough spoons today, you'll know that they're not talking about silverware. You're going to know that they're talking about energy, health, and just basic survival. So let's help spread awareness and empathy. Talk about the spoon theory. Look it up if you want to learn more about it. Very interesting. All right, we are into our events, and there's still so many events. I don't even know what's today. Okay, so today we've got the Ask a Doctor with Dr. Prakash begins at 6:30 p.m. Eastern tomorrow night. Tomorrow night, if you are liking our YouTube channel and subscribing and clicking the bell that says all, you're going to be notified when we come on here tomorrow at 6:30 going live. Get all your questions together. Share that all on your page. Get other people to put questions together, and they can pop them right up in Facebook or in chat here on YouTube. We have our final support group meeting of the month, general support group meeting. If you click right here on the link or you click above where it says support group meetings, all you have to do is register once and you'll get the link and then you can join the meeting. On Thursday, Dee Riete, who is one of our community liaisons, she is going to be taking us through a wellness aromatherapy 101 course. So that's going to be at 7 p.m. So she's going to talk about how she found our community, what her role is as a patient, as a survivor, and just something that's very important to her. Wellness is very important. And she is a licensed aromatherapy specialist. So this is not someone that just sells it. She works in an integrative therapy office. So Johns Hopkins offers integrative therapy, and integrative therapy includes acupuncture. It includes reflexology. It includes aromatherapy. There's so much to integrative medicine. So she's going to primarily talk to us about aromatherapy. And then beginning this fall and every quarter, she's going to take us through a seasonal class about blending your aromatherapy oils. Okay. And then we're going to learn how to make soap and all kinds of fun stuff with it. So she's going to become another one of our aortic artists or crafters. Okay, then on Sunday, as always, at 12:30, we have Qigong with community member Kevin Songer, and that takes us through very gentle, easy movements to help de-stress. But as with everything, you want to double check with your doctor that you're in a good place to do that. I think I'm pretty sure Monday night, the 29th at 6 p.m., unfortunately, that is being rescheduled with Melissa Patty, but we will be doing that in the beginning of October, controlling your future about wills and advanced directives. As of now, we do have the WISE, Women Inspiring and Supporting Empowerment. It is a women's only support group meeting on Monday, the 29th. That's always the last Monday of the month at 7 p.m. And then Tuesday, we're wrapping up our live series for Aortic Disease Awareness Month at 7 p.m. with Amy Wagner. She is an LCSWC. She is going to talk to us about the emotional toll of not only aortic disease, but any kind of health-related trauma, and if that causes PTSD, how to identify it, and ways to combat PTSD or just general anxiety and stress due to health-related issues. Busy still, so much coming, so much to do. Oh my goodness. And then I could take a little bit of a break. All right.
All right. So we have a bit of a back and forth going on here.
Okay.
So Natalie says my aorta ruptured when they opened me for surgery, and I'm also wondering about that third layer pseudoaneurysm. Molly asks, can you read your surgical notes? I believe some people choose to close that book and they never go back to it. So I wonder if that's where her angle is.
Yeah.
Please and thank you. Molly, have you been on blood thinners prior to the time of dissection? At which point Molly says, no, but I'm on Coumadin now due to my mechanical onyx valve. Tom shares that 2012, 25 years as a volunteer EMT firefighter, would not have known the difference between a heart attack and aortic disease. And I feel like that's probably still the same for many. Awareness needs to be raised. He points out that he got the Watchman to get off blood thinners. Let's see. Thank you, Miss Busters. Molly says, I find it interesting how so many of us had our dissections and surgery in the week surrounding our birthday.
We did? Many people did?
I don't know. Molly,
6 months
Molly
before.
might have a line on something. I'm curious.
I do know that when we've taken polls, it does seem that more people have it in the wintertime, but then also heart attacks happen more in the wintertime.
Hmm.
Yeah.
Please and thank you was asking about how long ago Molly had hers. She says 4.5 years ago, 6 days
Mm-hmm.
after her birthday.
Mm-hmm.
And
I was 6 months before mine.
and then the question, do you feel completely recovered? And that is a Pandora's box of a question to ask, to be honest.
Yeah.
When we hear from people all over the community, the ranges of recovery are vast,
Mm-hmm.
vast.
Yeah. They really are. I would have said that I think the majority of us um, learn to live, as Greg Greenberg would say, in this 2.0 state, different than before. You just have to learn to adapt to the way your body, because it is different. You have different blood flow. It just is different. But there are also people who might have been very physically active before. And so their mindset is we're going to get back to that. Therefore, they don't, I don't know that they really are as seriously impacted because they're still being active. Now, for them, they may see a change in that level of activity, but they're compensating because it's so important to them. But for a lot of us, um, whether it's comorbidities, I think you just learn to live with the new version of who you are.
Molly
But
gives
again,
an
it,
excellent
yeah,
response. She says, yes
yeah,
and no, but generally yes.
hmm yeah. I think I'm a no. I'm not who I was before, and I'm actually happy for it. I really am,
Do you feel
because the
completely recovered? Was the question.
no, I don't know that I'll ever feel completely recovered. I don't know that you
Again,
ever
yeah.
walk away from wondering is there something wrong. I think that scanxiety is a real thing. And I don't know that there'll ever be a day where you just feel like this is no big deal. It's going to go for a scan. I'm totally recovered, because you're never fully healed. Unless you're one of the ones that have their entire aorta replaced, then you're fully recovered because there's nothing else to happen. It's totally replaced, which is not necessarily true. If you have a connective tissue disorder, you can start dissecting in smaller vessels, right? You could have skin issues, bone issues, eye issues. But if you're not one of those people, and your entire aorta gets replaced, then there really is nothing left to worry about. You have an opportunity to fully recover, you know? But if you're not, stuff can happen at any time. But you have to learn to not really think about it, because anything can happen to you at any time. It's hard. It's hard to do, easy to say. But yay for those people that feel fully recovered. I think that's great. That's just definitely not me. All right. Do I need anything else, or we're good?
We're going to invite people to come see us tomorrow night at
Yeah,
6:30 for
we
Ask the
are.
Doctor live on Facebook.
We are. Hey,
And
you
then we're going to
guys,
ask people to like and subscribe.
yeah, we're also going to remind people that our seventh annual Hope Campaign video is out on YouTube. It's also on Facebook. It's also on the website. So if, we talk a lot about how some people talk a lot about how they have something in common with the celebrities, actors, actresses, sports figures, whether they're alive or they're not, that have had aortic disease. And I personally, my thoughts is I don't really have anything in common with them. It doesn't resonate with me. You, I have something in common with you guys, with people who start Facebook pages, with people who start nonprofit organizations that have this disease, or a caregiver to someone, with all of you that contribute daily and respond to our posts, or even come on here and interact with myself or anybody else who's gone live. That's who I have something in common with. So we have been asking for 7 years for people to submit their photos, themselves, their family, their dogs, their doctors, whatever it may be, and show the community what hope looks like, because you're the faces of aortic disease, all of you. And so that video is out, and it's so wonderful. It's so when everybody really loves seeing themselves and seeing people that they know, and friends that they've made in the community. So go check out that video and give it a thumbs up. And then we will have the illumination video out soon for you to enjoy as well. Yes, please click like, please click subscribe, and share this. Share what we've done here today, because I'm telling you, it's going to resonate with somebody, and we're going to find more people. So help us help others today by sharing and spreading our message of awareness, hope, and support. And yeah, I'll be seeing you guys tomorrow night at 6:30 p.m. Eastern. And if not, I will see you again soon. But thank you so much. Take care.